step back and let's deal with the case that perhaps you and I have probably seen in clinic before. So we have a 32-year-old male who is otherwise healthy, and they present to their primary care reporting frequent rectal bleeding. He's employed at the gym, and in fact, he's quite healthy and he lifts weight regularly. On physical exam by his primary care provider, the abdomen was soft. A digital rectal examination was performed, and it was remarkable for small external hemorrhoids. Labs were obtained given his report of rectal bleeding, and actually his blood counts were normal, hemoglobin normal. So the assessment by the primary provider was that this is likely hemorrhoidal bleeding. He was encouraged to supplement with fiber and avoid straining, especially since he works at the gym. The thought was maybe heavy lifting is causing the bleeding. So I want you to remember this case scenario because potentially you have also seen patients who have presented very similar to this, where they were advised to take fiber, avoid straining, and oh, it's probably hemorrhoids. Well, unfortunately, this gentleman, 3 months later, he returns back to his primary care and says, not feeling any better. In fact, I'm getting worse. Now I have daily rectal bleeding. I have fecal urgency. And in fact, I even had one episode of incontinence while at work. And he's also has been quite frustrated because he has frequently had to call in sick at work as well. Once again, a physical exam was performed and it was unchanged and really otherwise normal. This time, a hemoglobin was obtained and it's 10. So this time, the assessment is severe hemorrhoidal bleeding, and let's send him to a gastroenterologist. So he comes into our office and he's frustrated. He's tired. Some studies were performed in advance, perhaps in your clinic. Fecal calprotectin is elevated, 350. An in-office flex sig was performed. And as the images demonstrate here, there's the rectum, scored at a Mayo 2, and the sigmoid appeared normal. So this was defined as proctitis, and he was advised to start the aminosalicylate suppositories. He comes back a month later, and he says maybe a little bit of relief in symptoms, but he continues to report and endorse fecal urgency. He's happy he hasn't had additional episodes of incontinence. However, he now has worsening diarrhea altogether, including nocturnal symptoms of diarrhea, where at least once a night he's waking up to use the restroom. Again, a fecal calprotectin is obtained, and it's even more elevated, 600. So the recommendation is to start him on not just the topical suppositories, but the oral 5-ASAs. And he was also advised that we need to do a full colonoscopy. So within that initial period, the Flexig, now a full colonoscopy is recommended. And a couple of months later, he's able to get this scheduled. And there's the colonoscopy. The rectum, previously Mayo 2, now a Mayo 3, and the rest, sigmoid, cecum, the rest of the colon entirely normal. He comes back. He's frustrated. He says, I need something different. This is not working. I'm taking both oral and topical 5-ASA, and I'm still having only minimal relief. And he prefers to continue to have an oral therapy or treatment option. So in fact, he has started on an oral treatment option, and he asked to be returned for a follow-up in 3 months. So that's a presentation really of someone that I want all of us to be mindful of, because again, I'm sure each of us have experienced this type of clinic visit with a patient who's gone from primary care through into our office and continues to remain frustrated and just doesn't feel that the symptoms are being well controlled. And again, highlighting that impact on the quality of life. And certainly when it comes to isolated proctitis, we have to look at the different challenges that we experience with this condition and disease. Symptoms are variable. There's oftentimes a delay in diagnosis. It's not uncommon to think that the bleeding is secondary to hemorrhoidal, as an example. And the truth is, and I'm a clinical trialist, as are my colleagues here, this is a condition that is very much understudied among clinical trials. And certainly, as far as looking at the treatment and how we should initiate appropriate therapy for the right patient, there's such variability, again, given the fact that the disease is like limited to one segment of the colon alone. But again, as I started this conversation, and I think I really applaud the organizers for having this talk, what we have to be reminded of is recognizing that the disease segment alone does not define the disease severity. Let me phrase that again. Isolated proctitis, E1, compare that to E2 or E3, some more extensive locations or segments of the colon. You can see that on all accounts, whether it's progression of disease, as far as disease extension, risk for colectomy, or risk in escalation, or maybe advanced therapy or anti-TNF therapy in this case, you can see that it actually sort of mimics and aligns with each other in a sense of that risk for disease progression from isolated proctitis to more proximal disease, as I shared earlier. Certainly, we're seeing that over time, over years. That risk for colectomy, similarly, we're seeing that risk for need for surgery, and even I will add here for hospitalization, need for steroids, very similarly relates with that colectomy risk. And then when we're looking at that risk for needing advanced therapy, and specifically here anti-TNF therapy, you can see that it parallels. So again, as a reminder that just because of an isolated location of the disease, we cannot associate that with it being less severe. And as I mentioned, being a clinical trialist myself, it's not uncommon where unfortunately our patients, about 30% of patients suffer with isolated proctitis. And it's unfortunate that there is really truly an unmet need when it comes to clinical trials. Because of these patients, those who have isolated proctitis alone, so less than 20 centimeters of disease involvement, they have been historically and predominantly excluded in clinical trials. So this is quite challenging because we're emphasizing early appropriate therapy for the right patient, but certainly when there's a delay in treatment and then also progression of disease and that severity of disease, it could be quite disabling. And so our treatment options start becoming more and more limited. And once again, emphasizing that truly there is an unmet need when it comes to clinical trials and the eligibility of our patients who suffer from isolated proctitis.